It's unfair to be asked to follow Dr. Bowley and the bow pose that I will require all my fellows to do. All right, so dear esteemed moderators, everybody, thank you for the opportunity to talk today about sexual function preserving BPH LUTS procedures for prostates 30 to 80 grams. Here are my disclosures of note. I am a speaker for Library on behalf of Optilum BPH. All right, so if you look at the life expectancy in the US, you can see that the life expectancy is going up, and this is estimates for 2060, where about the average age life expectancy should be about 85 years. But as men get older, they're more likely to have a lot of the conditions such as BPH, ED, and ejaculatory dysfunction, which will tie into the rest of this conversation today. So if you look at the MTOPS trial, which was a study combining finasteride and doxycycline or combination, and if you look at the red line over years 1, 2, 3, 4, if you look at the placebo arm, you can see that even in the patients who were not treated, over time the erectile function and ejaculatory function decreased, suggesting that as men are getting older, they're getting more BPH, but also their sexual function may decline regardless of therapy. But the question is, does it really matter? Are older men actually sexually active? So if they're living to 85, are they going to be sexually active? Here are three studies, one from England, showing that 31% of British men aged 80 to 90 still masturbate and have sex. 60% of men 70 to 80 are still sexually active. From Indiana, about 40% of men over the age of 70 either masturbate or have sexual intercourse. And in Spain, men are pretty prolific. 2% of men over 65 are still sexually active. So the answer to the question, yes, men are still sexually active even when they're older. So a survey on BPH and sexual function showed that erectile function in men with BPH was important in 95% of patients, and ejaculatory function was important in 92% of patients. And if you looked at patients aged 70 years and above, 66% felt that maintaining erectile function is important, and 62% felt that maintaining ejaculatory function is important. So that's really important when you're considering the options for the management of BPH. If you look at surgery, and I know this will be addressed in the talks by my colleagues later, if you look at TURP, ejaculatory dysfunction can occur in up to 75% of patients, and ED in about 13 to 14% of patients. You look at enucleation techniques, again, about 76% ejaculatory dysfunction rates, and painful ejaculation is something that's not often spoken about, can occur in up to 20% of patients. Now looking at green light or PVP, again, about 2/3 of patients may have ejaculatory dysfunction, and painful ejaculation about 5% of patients. So again, these are things that patients are looking for options where they can circumvent these problems. And this is where missed procedures come into play. So I'll discuss 4 missed procedures in the next few minutes. So first we'll start with Resume, which is a thermal ablation procedure. You can see this is an office-based procedure. It can also be done in a surgery center. This is the handheld device that is inserted into the urethra, into the prostate, and a steam is delivered into the prostate and allows the prostate tissue to shrink and open up the passageway in the prostate. If you look at the 5-year Resume study, the study was randomized to Resume or sham, and 53 out of the 61 patients were then crossed over and treated later. And if you look here on the right is a little bit busy, but if you look at the erectile function scores based on IEFEF scores, and if you look at the ejaculatory function scores based on the MSHQ, ejaculatory dysfunction function, and MSHQ, ejaculatory dysfunction bother scores, you can see that they are maintained across the study. And these were stratified by presence, absence of baseline dysfunction, and these are the green, yellow, and blue lines that you can see on the right. Now, if you compare the Resume study to the MTOPS trial, the MTOPS again being the combination therapy, and you look at 3 years, you can see that Resume improves symptoms at 12 months significantly better than the medications and the combination medications, and the disease progression at 3 years was significantly lower with Resume compared to what you get with medications. So again, good data suggesting benefit with Resume. And if you look at the questionnaires related to sexual function, so on the left is sexual desire, and the right is erectile function. If you look on the left, the one thing that I'll point out is if you see the blue lines are Resume, the red line is placebo, and the green line is usually either medication or yellow line is doxycycline, and purple is combo therapy. And what you'll notice is with finasteride, whether single or in combination therapy, the sexual desire may go down, but with Resume it's maintained. And if you look at erectile function on the right, again, whenever finasteride was introduced, there was a decrease in erectile function, but it was maintained with Resume. Similarly, when you look at ejaculatory function, you can see a slight decrease in ejaculatory function with Resume, again, on the left side, the blue lines. And it's kind of similar if you look at the comparison between Resume and finasteride in terms of ejaculatory function outcomes. And if you look at overall satisfaction was highest with Resume compared to the other modalities. And again, this is further work by Dean Elterman looking at actually larger prostates, more than 80 cc's. Again, no significant changes in IEF at 12 months and no significant changes in the MSHQ function or bother at 12 months. Initial data on rates of ejaculatory dysfunction with Resume were lower than what we're seeing more commonly in practice, and I tend to quote my patients at about 10 to 20% possibility of having some ejaculatory dysfunction, which is important when you're talking to patients. Second option is UroLift, and the left is the original UroLift device, which was not the greenest device in the world. You had to come in with about 10 boxes whenever you needed to do a procedure. There's the UroLift ATC system, which is FDA approved to manage a median lobe, and on the right is the UroLift 2 system that saves you on some of the boxes. It's just you have to change the cartridge in the middle when you're doing the procedure. And here the goal with the UroLift is you're going to put these nitinol kind of clip things that are going to open up the prostate on the lateral and create an anterior channel of the prostate. And if you look at the lift study in terms of erectile function as stratified by sexual function at baseline, you can see that patients with severe ED had improvement in their erectile function. And if you look at guys with mild, moderate, and no ED, there was no change. And if you look at the ejaculatory function, again, this is a busy slide, but the gist of it is there is no de novo sustained ejaculatory dysfunction in any group, and the intensity and the volume may have improved in 20%, and the bother also improved. And if you compare UroLift to TURP and a 2-year prospective multicenter randomized controlled trial using the non-validated BPH 6 scores, better urinary outcomes with TURPs, better ejaculatory function compared to a TURP with UroLift, and no differences in ejaculatory bother between the two groups. A newer one is the iTind device. It's a temporary implantable nitinol device. It's placed with a flexible cystoscope, can be done in the clinic. You place the device, you leave it for 5 days, and then you can remove it again with a flexible cystoscope. So an advantage of not needing a rigid scope, and it's creating basically 3 incisions based on tissue necrosis in those areas. And if you look at the data at 12 months, without going too much into details here, but in the intention to treat, comparing iTind to sham, there were no differences in the sham or the IEF. This was even after stratification for various parameters. And there were no reports of anejaculation, decreased ejaculatory volume, painful ejaculation, or hematospermia with iTind. The newest player in the market is the Optolume BPH, and this is a new balloon that you place a preliminary balloon that is a pre-dilation balloon, and then you place a second balloon that is paclitaxel coated to decrease the hyperplastic response that you can get from dilating the prostate so it doesn't shrink back again. And there's the 2 trials. The first was the Everest trial, which was a single-arm, 5-year study, and this is the second trial, the Pinnacle trial, which is a prospective multi-center double-blind randomized sham-controlled study with 5-year follow-up. And here are the comparison arms where the treatment group was Optolume BPH in 100 patients, and the sham was 48 patients with basically an Optolume that was placed without being inflated. Outcomes were looking at LUTS in terms of IPSS, quality of life, BPH2, and functional in terms of QMAX, PVR, and some sexual function questionnaires, including IEF and MSHQ. And if you look at the data, you can see that Optolume had significantly improved flow rates in terms of IPSS, QMAX, and PVR compared to sham, as you would hope would be expected. And if you look at erectile function, you can see that the 2 arms or the 2 curves don't separate. No worsening erectile function with Optolume. More importantly, whenever we're talking about these missed procedures, is ejaculatory function. And again, here on the left is the MSHQ ejaculatory dysfunction function, and on the right is bother. And again, you can see no difference between the 2 groups. And there are no patients who have not been able to ejaculate after Optolume. There are 2% of patients who have had some changes in ejaculatory function. This is also important. You're implanting a paclitaxel. So the initial balloon, like I said, is not coated. The second one has paclitaxel. It creates an anterior commissurotomy and allows the prostate to stay dilated, but the paclitaxel may have an impact on semen parameters. This is looking, if you look at the bottom row is how many patients still had paclitaxel detectable in the semen analysis at 30 days, 3 months, and 6 months. And you can see by 6 months, a third of it, only a third still had any kind of paclitaxel detected. But the times are changing. This is an old study. This is from 2020 from Australia. But if you look, the red is TERP, the kind of pink is TUIP, and then you can see PVP is in the dark blue, light blue is HOLUP. And as you can see from 2014 moving forward, the orange is UroLift. You're going to see that there is more HOLUP and more UroLift. And what we're noticing, and more people are moving towards HOLUP for larger prostate, and missed procedure, whether it's UroLift, Resume, iTind, or the newest player again, Optilume. And we have a bunch of stents that are coming into the market in the near future. So there is a move towards missed procedures for smaller prostates to preserve sexual function. So in conclusion, LUTS, BPH, and sexual dysfunction are prevalent. Ejaculatory function is very important to many men. Oral therapy carries high risk of ejaculatory dysfunction and ED. Surgical options carry low risk of ED and high risk of ejaculatory dysfunction, and missed procedures carry low risk of ED and ejaculatory dysfunction. And I'll just plug in here the last part here, the video journal of sexual medicine that has a whole section on BPH. So if you have any BPH videos with any of these procedures, please feel free to submit them. Thank you.